Hello, welcome again to another edition of Matters of the Heart, brought to you by Haverhill Community Television and Pentucket Medical Cardiology. I'm Seth Bilazarian, a clinical and interventional cardiologist with PMA, and I'm here with my colleague, Dr. Srivavastava, a clinical cardiologist with our group as well, and he's going to cover the topic of signs and symptoms. What's critical for our patients to know and the public in general to be aware of symptoms that would require, in our view, medical attention. So he's going to cover three important medical or cardiovascular problems: stroke, heart attack, and congestive heart failure. And what kind of symptoms people might be experiencing, either somebody in the audience or somebody, a family member of somebody in the audience, that really warrant seeing a primary care doctor initially or potentially a cardiologist. So I'm going to turn it over and ask you to take it over.
Great, thank you. Thank you for the introduction. And I guess I view this sort of as almost like a public service announcement and trying to get out there some of these warning signs that are very serious, and it makes a big difference to seek out medical attention quickly and promptly for a lot of reasons that we'll talk about, and just try to educate patients or the public about this. I'm sure both of us have stories about people who developed some symptoms, they weren't sure, they stayed at home or called their brother out in California to get his advice, and they just waited and waited, and bad things happened as a result of not seeking out the prompt medical attention. So the first thing I wanted to talk about was heart attack. And heart attacks, generally speaking, are due to a blockage in a coronary artery. And the most common symptom that we talk about is chest discomfort. We say chest pain, but often many people will correct us and say it's not really pain. It's often described as chest pressure, tightness, heaviness. The phrase a lot of people end up using is, feels as if someone's sitting on my chest, or as if there's an elephant on my chest. People often will do this, put their hands up on their chest. That's referred to as the Levine sign. And that's the most common, well-known sign or symptom of a heart attack. And it can be relatively sudden in onset and very severe. In that situation, there's not much doubt by most people about what's going on. It's the kind of thing you hear about you see on TV. People just grab their chest and they're in severe discomfort and they can't breathe. Most people don't mess around with that type of symptom, and they, EMS or 911 is summoned, and they're brought promptly to the emergency room. But not everyone has such dramatic, severe, or sudden symptoms as that. Some people still have the chest discomfort, but it can be vague. It can be associated with some other things sometimes. One could be in a cold sweat, be short of breath. The discomfort that's in the chest can sometimes radiate or travel up to the jaw or neck or throat region, sometimes to the arm. It can be both arms. It's not always the left arm. Many people think just the left arm. It can be the right arm as well. It can go through to the back. People can sometimes be nauseous or vomit with it as well, or have some abdominal discomfort. So those are some of the more common associated symptoms one may see with a typical heart attack. And so if one starts to develop these types of symptoms, we tend to tell people that they should seek out medical attention immediately. And I don't mean call the doctor and go to his office. Just call 911 and be brought straight to the hospital via an ambulance. We do know that people who are taken to hospitals via ambulance get seen much more quickly, is one thing. But two, if there are any severe problems going on, EMS staff can tend to much more quickly. If one should have a cardiac arrest, for example, you can start resuscitation measures right then and there with EMS, whereas bringing somebody in a car really slows down any of these efforts. So we really do recommend calling 911 and being brought to the emergency room via an ambulance. What else to say about heart attacks? Now, one thing we hear a lot about in the press is, are symptoms different for women versus men? By and large, women, when they have heart attacks, it still is chest pain, just like we talked about. But we do know that sometimes women have slightly different symptoms. Also, as one is older, the elderly, their symptoms can sometimes be a little different. Sometimes shortness of breath is the only predominant symptom, or sometimes nausea, vomiting, abdominal discomfort, or lower chest right in the middle here. That might be the predominant symptom, or dizziness or lightheadedness. So other symptoms that may not be textbook for a heart attack also come into play here as well.
As you were talking, we've all heard these stories, and we've heard the unfortunate stories, as you described, of people who delayed coming in. Some of them, of course, die because they have a cardiac arrest, for instance, and they didn't come in. Some patients wait days and their heart attack is complete, and then unfortunately there's no chance of recovery for the heart attack. So there's a variety of bad reasons that happen, bad things that happen when people wait, so we know that. But as you were describing it, I was trying to say, how can we distill this message to the simplest message? Yeah. And I guess the question is, why not go to the hospital or call an ambulance for any sudden onset of any new chest symptom that lasts more than a few minutes?
Yeah, I think it's reasonable. Also, I mean, there's many people or patients who have had stents and heart attacks and different things, and you know, they start to learn about their symptoms and they're treated differently.
That's why I said new. That's why I said new.
Yeah, new. So a new thing, absolutely. Yeah, if you want to boil it down to something, a very simple message, new sudden chest pressure, just
or any symptom, because we said how it could be burning, it could be other symptoms as well. So rather than trying to say, have patients try to figure it out, because we've all had this situation where I thought it was heartburn, or I thought I pulled a muscle shoveling snow. We've had these issues, and sometimes it might have been, but you know, the safe rather than sorry strategy. So I guess as you were talking, I was trying to carefully think about what could be a message that we could give the patients, and is it reasonable? I'm asking you to help any new sudden onset discomfort in the chest that lasts more than a few minutes.
Yeah, I think it's a very good, simple message to deliver.
Because we say that if it lasts a second, or just to be clear, it's not a heart
issue. That's what I want to be clear about too. So a lot, you know, people get these, you know, you and I, everyone gets these little pains every once in a while. You could be doing something and get a sharp jab that stops you dead in your tracks for a second. You move on, and who knows? That could be just something musculoskeletal. It could be a gas bubble in your stomach, or it can be a lot of things. But that type of pain, generally speaking, is not coming from your heart. And, you know, the type that goes away just as quickly as it came, just within a second. I wouldn't want people to dial 911 for that all the time.
So that's why I use the few minutes idea.
Yeah, absolutely. And yeah, I think it's a smart approach is to boil it down, make it simple, remove excessive thought and analysis from the situation as well. Because I think people do overthink. People rationalize it. People start to think of what else it could be. And I mean,
I really want to emphasize this point because we've both been practicing a long time, so we've seen these issues. So just this morning at 3 o'clock in the morning, 51-year-old lady with no heart history. She was a smoker, went out for dinner with her husband, had some chest pain, decided maybe it was from heartburn. She went home, went to bed. She woke up 6 hours later. Pain was severe, came to the hospital with a very large heart attack. Half of her heart is now wiped out. So it's unfortunate because she delayed coming in. Now, she might recover, but she might not. Had she come in right from the restaurant, excellent chance of recovery. And we also have those other cases of patients who come into the hospital and within minutes of coming to the hospital, or as you said, en route in the ambulance, their heart stops. They have the cardiac arrest, and we could use the paddles, the electric shock, to bring them back. If the patient jumps in the car and they drive themselves or a family member drives them, that's not an option. Those patients will probably not survive.
Yeah, no, absolutely. Well, it's funny, you were telling that story, and it just made me think of a story of how people like to think it's something else or rationalize. I had this young guy recently, 40s, fit, runs, exercises, and he said to his doctor, every time I run, I get this indigestion. So he starts himself trying to take antacids and everything else, and sure enough, he ends up having a heart attack and goes on to get bypass surgery. And he says to me in the office recently, all my indigestion's gone now. And I said, it wasn't indigestion, and he still thinks it was indigestion all along here.
Sure. Well, I think you're making an excellent point because I've had that experience as well. Just to use, I think that one of the things that happens is that patients use the word indigestion, and I will just caution people that if you go to the emergency room and say this is indigestion, you might mislead the doctor. You don't know if it's indigestion is a diagnosis. It means it's acid in the stomach. Don't say you have indigestion. Say you have what you have: a pain, a burning, a tightness, a squeeze. Use descriptive terms because it can help the doctor and not mislead the doctor. I would say that's important.
I think for a lot of people it's comforting to think it's just going to be indigestion and want it to be just indigestion, certainly.
But we've all had examples of because of that it was treated as indigestion because the assumption was it was something they had before as indigestion.
Right, absolutely. So, no, that was interesting. So what I want to talk quickly, though, you call 911 when you get brought to the hospital and just kind of quickly talk about what happens to you there. And a lot of quick things happen when you're coming in with pressure across your chest and an intravenous line or an IV is put in, blood is drawn. But what the most important test for us right off the bat is the EKG, and that's where they put stickers on the chest, measure some electrical impulses across the heart, and it can tell us right off the bat, are you in the throes of having a heart attack, or certain types of heart attacks right now as we speak. and it can alert us very quickly that we got to move fast here to go to a procedure that you do, the procedure you do that you just talked about, where you go in and open up an artery and put a stent in. And so a lot of this can happen very quickly in the emergency room. There's not a lot of time to be talking about it and debating about it because time is heart muscle.
The only thing that you said that I want to clarify, which I know you know, but you said one thing that was incorrect. You said the EKG would be done in the emergency room. Actually, one of the other advantages of the ambulance is it's not done in the emergency room. It's done in your living room.
Yeah.
So if you call ambulance to your home, the EKG is done in your home.
That's a key thing.
And right at that point, we know whether you have that kind of heart attack that needs an emergency angioplasty or whether it can be treated in a more calm way.
Yep. Now, I've been in the emergency room numerous times doing other things and get over here a call coming in from the EMS saying, hey, we just got this gentleman, he's got this type of heart attack, we're coming in now. And so everyone's alerted, ready to go. Calls are being made to get the right staff in place to then really expedite treatment. Because we do know the faster one is treated, the better off they are, just like the woman you described earlier that may not fare quite as well because of the delay in treatment versus someone who gets in there very promptly, less than 90 minutes from the symptom onset. They do much better, certainly. So it's important. It really is important. And I can't underscore enough the importance of using 911 as opposed to calling your son down the road to wake him up in the middle of the night to come up, pick you up, think about it, then maybe drive to the hospital. It just wastes a lot of critical time.
I agree.
So
we just want to emphasize again, you may even be going to the wrong hospital because some hospitals are equipped for this kind of heart attack care and some aren't. So that's the other reason to...
Right, that's an issue locally certainly, and the EMS, the EMTs, it's a well-oiled system and machine. They know exactly where to go and how to do this, and so it's all the more reason to call 911. Well,
that was great. So that was a fantastic review of warning signs of a heart attack. I know you have some more in store. So what's the warning signs of a stroke? What is a stroke?
Yeah, so a stroke, you can think of it almost like a heart attack. It's often a blockage of blood flow to the brain, and there's different types of strokes. Sometimes people can have a stroke because a blood vessel has ruptured and they're bleeding into their brain. That's the much less common kind. The more common kind is due to a clot or a clot traveling up and blocking off blood flow, and same kind of process as a heart attack, so to speak. And so there are...
So the heart attack is a little bit of heart muscles dying, or a lot, but some amount of heart muscles dying, and a stroke is the same thing but brain tissue dying.
Yeah.
Okay.
So both obviously vital things to be taken care of promptly. And I think many of us may know the signs and symptoms of a stroke, but I went and looked up what some of the different societies, American Heart Association, American Stroke Association, what they're trying to get out there as a message. And we'll talk about some of this, but the sudden development of weakness or numbness of the face, arm, and leg, especially if it's just one side, that's a sign of a stroke. Sudden confusion, trouble speaking, trouble understanding, that's a sign of a stroke. Sudden trouble seeing in one or both eyes, that can be a sign of a stroke. The sudden onset of a trouble of walking or losing balance or falling to the side, that can be a sign of a stroke. A sudden severe headache, that's probably considered the worst headache you've ever had. That can be a sign of a certain type of stroke as well. So those are some of the general symptoms here that people have. Now, there's lots of different public service messages that have been created and commercials on TV or public service announcements on TV to really educate the public about some of these signs and symptoms. And there's one where the American Academy of Neurology, the American College of Emergency Physicians, the American Stroke Association, the American Heart Association, they formed this stroke collaborative that came up with this public service campaign called Gimme 5. And it's 5 things that a layperson can do to assess a loved one or a friend or someone else who might be having a stroke. The first one is walk. You have the person walking. Is the balance off? So that's one sign. Then you say talk. Is the speech slurred or is the face drooping? That's another sign. Reach. You ask the person just to hold out their arms, for example, and if one arm just drifts down, and that's a sign as well. See. Is their vision all or partially lost? That's another sign. And then feel. It's referring to, do you feel the pain of the headache? Is the headache the worst headache you've ever had? And so these are some of the simple tools that a layperson could use to assess a loved one who's having some altered sensorium or strange symptoms to ascertain whether or not you should be getting to the hospital.
So the 5 you said, Gimme 5 is walk, talk, reach, see, and feel.
Yep.
Walk, talk, reach, see, feel.
Yep.
Okay?
Yep. So not too hard to remember, certainly not. But again, just like with heart attacks, the key, it's vitally key that 911 is called immediately, that you don't wait hours or think about it, or again, call your cousin out in California to see what you should do, or wait till the morning to call your primary care physician when the office opens up.
Resources.
Yes, or looking up, right, exactly, looking things up on the web. It's just like with the heart. Time is muscle, time is tissue, and you want to get seen right away. And again, 911 is the best way to do that.
So you did a great job telling us what happens if you get 911 and you get rushed to the hospital with a heart attack symptom. What happens with the stroke symptoms?
Yeah, a lot of similar things. You're assessed, generally speaking, like one would be with vital signs and blood pressure and heart rate. And emergency room physicians and EMS servers are very skilled at doing a true neurologic physical exam. So you can do certain tests on a physical exam to figure out what's going on. But the key is to get into the emergency room, and one of the first things that's done, much like the EKG for the heart, a CAT scan of the head. It's a very important initial test because certain types of strokes, although a minority of them, can be due to bleeding in the head. And so that's a CAT scan, the vital test to make sure that that's not the cause. If that's not the cause, then it sends you down a path of certain types of treatments. And this is very important, where time is an important thing. Getting to the emergency room promptly. We know that if you get there within it's different, you know, some people say 4.5 hours, 6 hours, you can use a certain type of medication, a clot busting medication. It's called TPA. It's a clot buster as a way, and it can be given as long as you don't have certain other problems, but it can be given, and that's the best treatment by far for an acute stroke that's due to a clot traveling up to the head. If one had a bleed in the head, of course, you would not be giving a clot-busting medication. That's why that CAT scan is vital initially, and also that's why getting to the hospital promptly is vital, so you can be a candidate to benefit from this type of therapy.
Okay. So we got the Give Me 5 you went through. We won't review those again. You get to the hospital, and if you don't have any kind of bleeding on your CAT scan, you're a candidate for this clot-busting medicine that can make your stroke either go away or at least smaller.
Yep.
So the idea for our patients is that with the heart, we're trying to protect the heart muscle, but in this case, if you have extreme weakness on one side or extreme speech difficulty, the hope is that by giving this medicine, you might have very little, maybe just a little bit of weakness or a little bit of speech difficulty, which would be a good outcome.
Yeah, you can, and I have countless number of people who end up with complete resolution of all their symptoms and have no deficit afterwards, and that's the best of everything. Now, there's another thing called a TIA, Transient Ischemic Attack. Many people refer to it as a mini stroke, or it's a warning sign that something's coming. And what that is, without getting too technical, is you start having the symptoms. You say you have a facial droop and the arm and leg are weak, but then it resolves after a few hours. And that's actually a very important thing, because we know that people with a TIA are at very high risk to subsequently have a stroke. And the highest risk of that stroke is within the first 48 hours after this TIA. And I think sometimes we might not take, we meaning medical community and also patients, might not take a TIA as seriously as we probably should. And so there's been a lot of work being done to figure out who is at high risk for a stroke and who might not be, and how you evaluate these people. Because often, you know, we see people come in, no, their speech is slurred for an hour, but then they're back to normal. And so we need to come up with a better system of figuring out, well, are they really at high risk for having a stroke now? And so there's a scoring system that I came across that is referred to as the ABCD2 scoring system. And it's looking at A, age, B, blood pressure, C, clinical features, D, diabetes, and the second D, duration. And the scoring system, these are large studies looking at this, is age greater than 60, you get a point. You get a point if your blood pressure is greater than 140. You get 2 points if you have weakness on one side. You get 1 point if your deficit was speech impairment without weakness. 2 points if it lasted longer than 60 minutes. 1 point if it was less than 60 minutes. And 1 point if you have diabetes. And this can be done right in the emergency room, and you can add up the points and come up with a score. And these studies have shown that those who have a score of 6 to 7 points are at high risk for stroke within the next 48 hours. 8% risk of stroke in the next 48 hours. That's a lot to me, 8%. 8 out of 100 people having a stroke.
1 out of 12.
Yeah, that's a lot. That's a high risk thing. 4 to 5 points is moderate. They're 4% risk. I still, I wouldn't want to be told that you have a 4% chance of a stroke in the next 48 hours and not do anything about it. Then zero.
What risk of stroke would you be happy with?
Oh, yeah, exactly. So, fair point. Well, 0 to 3 points is low, 1%. And many societies advocate and really recommend that those with the high and moderate risk actually be admitted to the hospital and have a very comprehensive evaluation as to what might be the cause of their stroke. So getting their heart looked at to see if there's clots in the heart, for example, looking at their heart rhythm to see if there's an irregular heart rhythm, looking at their carotid arteries or the vasculature, the blood vessels inside their head to see if there's blockages there as well. Checking cholesterol, blood pressure, and getting very aggressive with all these things. And all these things can be done very promptly within a hospital setting, whereas once discharged to home, it might take a little bit longer for a lot of these types of things to get done.
Okay. Very good. Well, that was a fantastic review of strokes. I know you have one more topic, and that's the topic of congestive heart failure. So I'm interested in hearing what signs and symptoms our audience should know about and be thoughtful about. And I'll just remind the people in the audience, we've talked about congestive heart failure in the past, and it's the #1 reason for hospitalization. It's the #1 admission cause, so it's not infrequent.
Yeah, absolutely not. It's what I see people the most for. Congestive heart failure, it's really kind of a ugly term. It has such a negative connotation to it, but I think one way people can think of it is fluid retention. And that fluid retention, or your heart's not pumping strongly enough, can lead to an assortment of symptoms. Some of the most common symptoms are shortness of breath, especially with exertion. People start to get winded when they start to do activity. Well, let me rephrase that. The more severe the congestive heart failure is, the more easily one might become winded. So in some early instances, people might become winded only when they climb a couple flights of stairs or if they're carrying heavy bags into the house. But in its more extreme form, people can be winded just walking across the room or walking down the hallway. Or even its extreme form at rest. But that's where it really been let go to the end there. So shortness of breath or shortness of breath with exertion. People can start to have difficulty sleeping when laying flat. They start having to use pillows to prop themselves up because one can think of fluid in the lungs, for example, and so you have to prop yourself up. In its extreme form, people can wake up gasping for air in the middle of the night, have to dangle the legs over the edge of the bed, or even open up a window to get fresh air. That's also a sign that it's really gotten along pretty far. People can develop swelling in their legs. That's a very common symptom from congestive heart failure. The legs start to swell up. People can develop swelling elsewhere, often in the abdomen. It's a very common place. The abdominal girth increases. Weight gain is present. People's rings might be not as loose fitting as before. Clothes are tighter. These are all signs of congestive heart failure.
So you made a long list of congestive heart failure, and that was great and comprehensive. But I want you to help clarify something that we hear about a lot in the office, and that's the issue of a patient who will say, I was getting a lot more short of breath, but my ankles weren't swollen, so I thought it couldn't be congestive heart failure. So if you could address that one question.
Yeah,
and also the second question is, how concerned should patients be about ankle swelling? Those two questions I'd like you to...
ankle swelling warrants an evaluation, but ankle swelling can occur for a lot of different things, and I think one's doctor can certainly help guide people to what their ankle swelling is from. People can have ankle swelling from certain medications. People can have ankle swelling from the veins not working as well in the legs, venous insufficiency, or people can have ankle swelling from thyroid disorders. There's a lot of things that can cause ankle swelling. So it warrants an evaluation, certainly. It's not something to just blow off, I don't think.
But before being evaluated, I would want to say and ask for your opinion. In general, ankle swelling in its own right is really not something to be too nervous about. A lot of times our patient will come in and say, I'm very nervous about this ankle swelling.
It's not life-threatening. These are not, we talked about heart attack and stroke, emergency, life-threatening things, call 911, get to the hospital. This is, you notice these symptoms, call your doctor, make an appointment, go get evaluated. It's not, drop everything, dial 911, not at all, no. Okay. So no, it's very different.
But in the scheme of the ankle swelling versus the shortness of breath, put those two in terms of seriousness issues.
Yeah, well, also certainly, the shortness of breath is a more worrisome symptom. I will say this: there's plenty of people who could have severe congestive heart failure, and you can't see an ounce of fluid in their legs at all, but can have severe congestive heart failure, and vice versa. There's plenty of people who fluid is built up in the legs tremendously or the belly. You listen to the lungs with the stethoscope and they sound pretty clear. So just listening to the lungs and having clear lungs doesn't exclude the presence of congestive heart failure by any means at all. So shortness of breath, that warrants evaluation. That's a worrisome symptom, certainly.
And all, just like you said, all ankle swelling is not congestive heart failure. All shortness of breath is not heart failure.
Absolutely, right. I mean, you can have shortness of breath for a lot of reasons. Even, obviously people have lung issues or smokers, there's emphysema, COPD, but there's a lot of, a long list of things that can cause shortness of breath that I'm not going to get into. But the point of these symptoms that we just went through, certainly warrant some evaluation. And there's other symptoms that are a little more insidious or a little less obvious, especially in the elderly, just generalized fatigue, lack of energy, malaise, lack of appetite. That can sometimes be a less obvious sign of congestive heart failure. And so usually, when you get evaluated by your doctor, and I know we're running up against the clock, so sort of, cut to the chase here, there's lots of things that can be done to, a good history taken by the physician, a very a physical exam, certain things that we look at from a cardiology standpoint to look for fluid retention. I think looking at one's neck, the jugular vein is probably, for me, probably the most important, easiest, simplest, and best, most useful way to assess someone's congestive heart failure. I'd rather have that. If I had to choose between that and listening to the lungs, that would be a much more useful test for me. Looking at the vein to see for something we call jugular venous pressure. You can actually measure the pressure that comes as a result of fluid retention and gives us a very good idea of how much congestive heart failure one is in. So listening to, doing a comprehensive physical exam, there's some basic tests that get done, blood work that gets done. A cornerstone of our evaluation is an echocardiogram or an ultrasound of the heart. Certain scenarios you may want to be doing stress testing to look at things, and so these are all standard tests that we end up doing. But again, these are routine doctor visit type of things, not rush to the emergency room type of things, unless one lets it get so severe to the point where you can't breathe even while you're sitting at rest. And I've seen people who let it get that far and they end up in real trouble in the emergency room.
Well, we have to wrap up. What a fantastic tour de force review of symptoms of heart attack, stroke, and heart failure. Hopefully this will save a life. Hopefully somebody out there will hear about this, or a family member will get someone to attention, and we hope this provides a service to our community. So until next time, I'm Seth Bilazarian for Haverhill Community Television and Pentucket Medical Cardiology. Thanks to Dr. Srivavastava for joining me with this excellent review of signs and symptoms. Until next time, good night.